we have that enzyme, which is the CYP450 enzyme, and this one is limited by azoles. You're right. Now, how do you classify azoles? Tell me. We have triazoles and give me examples. Triazoles, we have examples like fluconazole, itraconazole, voriconazole, right? And then the imidazoles,
We have
ketoconazole, miconazole, clotrimazole. So why was ketoconazole withdrawn from the market? What is the issue with it? It's because there's fetal hepatotoxicity, and we also know ketoconazole interferes with biosynthesis of testosterone.
Yeah.
So it causes gynecomastia and the likes, okay? Let's proceed. Apart from the azoles, then we go to which drugs now target ergosterol cell. The Pauline macrolide. Like amphotericin B and nystatin, not so. Okay? So, amphotericin B is widely used for a lot of infections. What are the major side effects of amphotericin B? How do you classify them? Classify them into infusion-related side effects and cumulative side effects. The infusion-related are related to when this drug is being infused. Okay, it releases histamine, which can cause hypotension, fever, and chills. That's why sometimes these patients are given antihistamines, paracetamol, those corticosteroids. How about when it comes to the cumulative side effects of amphotericin B? Nephrotoxicity. How does it cause nephrotoxicity? It causes nephritis. So we have ototoxicity also can be there, hypokalemia, hypomagnesemia, anemia itself can be a side effect of amphotericin B. Finally, as we summarize, how are the side effects of amphotericin B mitigated? We know it causes nephrotoxicity. By the way, what monitoring parameters are important if someone is on amphotericin B? What tests do you think could be done for a patient to minimize this toxicity? One, renal function tests, because we know the drug is nephrotoxic. Then
the electrolyte.
We can do electrolytes because we know the drug can cause hypokalemia, it can cause hypomagnesemia. Okay. Then, how do we minimize these side effects?
We build. I think it's related to how the person is using the hydrogen.
Yes.
We encourage them to have fluid.
Let's talk about busulfulvine. What is the mechanism of busulfulvine? Yes, what is it used for? It is a mitotic spindle inhibitor, not so. It's used for these dermatophyte infections.
For onychomycosis.
It can be used for onychomycosis, it can be used for tinea, carpitis, cophoris, and the likes. How about 5-flucytosine? Where does it belong? It is a pyrimidine analog.
Yeah.
What are the side effects?
Low platelets,
bone marrow suppression, hepatitis, and then what are the clinical uses of flucytosine? Meningitis. They use it a lot in meningitis. Do we have other drugs? Boric acid, sulfuric acid. Boric acid is used for what? People who have those chronic candida infections, vaginal candidiasis. What about fluconazole? What do you know about fluconazole? If an antifungal that belongs to the azoles, not so. What is it used for clinically? It's used for fungal infections like meningitis, candidiasis. How about what is secondary prophylaxis? You know, these patients who have cryptococcal meningitis, after they have been treated, they have to continue fluconazole for some time, like 1 year. We call that secondary prophylaxis to promote resolution. Okay?
Yeah.
So what have you learned? Anything you can give? Take home points?
Generally, for antifungal, what I've learned is I've learned how their mechanism of actions, how we group them, how we have those ones that attack the cell membrane, those that attack the cell wall. We have talked about those ones that attack conversion of lanosterol to ergosterol. Very good. Yes. Then we also talked about those ones that attack the cell wall itself. Yes.
Fortunate, what is your take on from this?
Antifungals are very interesting. I've learned about amphotericin B, like it's what
It's
side
toxicity,
effects.
yeah.
I've learned about conazole. I didn't know it's fully conazole.
Fun.
Upon conazole.
I'll remove that part.